and then I'll let you. Okay, so hi everyone. Thank you for joining the Division of Rheumatology Grand Rounds. A couple of reminders before we start the session. This session is being recorded and it will be posted later on our website. There will be a Q&A session at the end, so please add your questions in the Q&A feature and not in the chat box, so it's easier to moderate. And now I'll let Dr. Andrews introduce our speaker for today.
Thanks so much, Danielle. It's my pleasure to introduce Dr. Julie Paik. Dr. Paik is assistant professor in the Department of Medicine in the Division of Rheumatology University. She's a member of the Johns Hopkins Scleroderma Center and specifically as director of clinical trials at the Myositis Center there. With respect to training, she did her medical training at George Washington and then residency at UCLA and fellowship at Johns Hopkins, as well as a master's at the Bloomberg School of Public Health there. Her clinical and research expertise is in the areas of myositis and scleroderma, and with a particular interest in the skeletal muscle manifestations of scleroderma. From a research perspective, her K23 from NIAMS focuses on developing novel methods to predict adverse functional outcomes among scleroderma patients, and specifically those with skeletal muscle myopathy. She also has research interests in cardiomyopathy and the use of novel MRI techniques in scleroderma and myositis. And then finally, and of particular relevance today, she's led a trial of tofacitinib for the treatment of refractory dermatomyositis. Dr. Paik is very involved with the ACR around myositis and muscle biology. And she's given many talks around the world on these topics. She's the author of 70-odd publications, and her talk today is entitled Promising Therapeutics in Dermatomyositis. And so I thank you very much, Julie, Dr. Paik, for being here today. I'll turn it over to you.
Great. Oops. Sorry about that. Thank you for the generous introduction. I think it's super generous and very welcoming of you. And it's truly honor and pleasure to be here at University of Washington virtually. I myself grew up in California, so I have a special place in my heart for the West Coast, even though I have been in the East Coast for over 11 years now. So without further ado, I will be talking about promising therapeutics in dermatomyositis today. So these are my disclosures. And this is obligatory copyrighted material slide that Hopkins requires us to put in. So the outline of my talk today is as follows. First, I'll be discussing a brief overview of the clinical manifestations and pathogenesis of dermatomyositis. And then I will delve into the current treatment algorithm of dermatomyositis, and then layer in recent clinical trials and a recently FDA-approved drug for dermatomyositis, which was very exciting because it's the first FDA-approved drug. And then I will largely focus my talk on the evolution of JAK inhibitors in refractory dermatomyositis, largely because, as Dr. Andrews mentioned, we completed a proof of concept trial of tofacitinib, a pan-JAK inhibitor in dermatomyositis at our Myositis Center. So I'm speaking to a lot of experts here in the University of Washington, all these rheumatologists. I know you guys were one of the biggest groups here in the West Coast, but just to briefly go over the dermatomyositis as a subgroup of the idiopathic inflammatory myopathies. And as I always tell fellows who come and do training with us, it tends to be easier to diagnose because the patients have clinical manifestations that you can see on exam. So the cutaneous findings, the classic Gotrin's papules on the hands, named after Dr. Gotrin, a dermatologist who noted it first, a German dermatologist, and then also the heliotrope rash, because named after the heliotrope flower because of the purple color of the petals of the heliotrope flower. And in the bottom picture, these are things I probably don't think about as much, but I always have my patients in our myositis center when I'm working with the fellow, make sure they're completely in a gown so we can make sure we don't miss other areas of a rash. I like to put this picture in because, I have a 10-year-old son who had severe eczema. And if I just looked at this picture, I would say this looks like my son's knees. So patients can look like, the skin can look like eczema. And so this is when we lean to our dermatology colleagues to do a biopsy, either of the Gottrin papule if you're not sure, or even the heliotrope rash. You might wonder, how can I do a biopsy of the eyelid? I actually had a patient who had very mild heliotrope rash, and she didn't have any muscle involvement, but she did have, later we found out she had an autoantibody panel that was positive, but the dermatologists are amazing, as you might well know, and they were able to biopsy her upper eyelid right here close to the eye brow and find the diagnosis of dermatomyositis based on interface dermatitis. So if we're not sure, we can do the biopsy, but certainly the key point here is on these pictures, it can mimic other rashes that can be really itchy, scaly, and red. Don't want to forget about patients who have darker skin, more melanin. It can look post-inflammatory, but you want to look in these areas because it can look very hyperpigmented and not look as red. And because we're in Baltimore, we do have a large population of Black patients. And so we're very sensitive to the fact that, you know, when you're trying to do a cutaneous disease activity, you know, severity index score, the CDASI, it may be a little bit harder to tell in patients who have more darker skin. In patients, we also don't want to forget about the muscle involvement. Proximal muscle weakness is classically found. And I always tell my fellows, you want to look for the neck flexor muscles. And, you know, you really can't test that when they're sitting up. They need to be lying flat and supine. And you want to check the neck flexors because it's one of the earliest muscle groups that can be involved. Okay, so when you compare across different subgroups of myositis, dermatomyositis tends to be more homogeneous as a group when you compare them to inclusion body myositis or polymyositis, if that really exists. But in the spectrum of dermatomyositis, you can see it's pretty wide. And this figure is adapted from Ghazi et al. From Medicine 2018, but I like how it simplistically shows you the breadth of dermatomyositis. You know, first you have amyopathic, where you have skin predominant disease with skin only that you'll see, but not to reassure you that just because they have amyopathic disease, they're going to have easy to treat, you know, easy to manage disease. I mean, these patients can also have lung involvement, right? Like MDA5 associated interstitial lung disease, rapidly progressive. So these clinically amyopathic DM may have mild skin, but can have other internal organ involvement. Hypomyopathic dermatomyositis, these patients will have more, you know, skin involvement with mild, some evidence if you actually had to look for muscle involvement, like a CK elevation or muscle edema on MRI. And then you have the classic DM, where you have, you know, skin and muscle involvement. And this is just to set the stage that the spectrum of dermatomyositis can be quite wide. Now, do we really need to do a biopsy, a muscle biopsy in our patients with dermatomyositis? I think we go back and forth with the neuromuscular folks. You know, I think neuromuscular folks are kind of trained to do a muscle biopsy in all patients with myositis, which I don't think is completely wrong, because if you do have a dermatomyositis patient, sine dermatitis, where they don't have skin disease, then you certainly want to do a muscle biopsy to see if this patient has dermatomyositis. But in reality, in our myositis center, what we tend to do is if they have skin involvement, it's classic, we really don't need to do a muscle biopsy. But if we did do a muscle biopsy, the classic feature we see is the perifascicular atrophy here, with in the perifascicular area, where you have these myofibers that are smaller, and you also see perivascular inflammation. What are the other organ manifestations that you see with dermatomyositis? We don't want to forget, as I mentioned before, we do not want to think simplistically and think, you know, dermatomyositis is easy to treat because you can actually get internal organ involvement with other organs like lung. This is a patient of mine who actually had MDA5 associated rapidly progressive ILD. And unfortunately, this patient didn't make it. I mean, he had very mild skin disease, and he was already in the ICU by the time we met him at Johns Hopkins Hospital. I remember this patient. It was one of my first patients with MDA5 when I was a fellow, first-year fellow. Then we also have other organ involvement, the calcinosis. I'm putting this here. This is a striking image of a patient with JDM who has calcinosis, and you can see they're sheet-like, which is very different from scleroderma patients who get calcinosis. And these patients in scleroderma, you'll actually get them in the fingertips versus in dermatomyositis. We all know that this will be more sheet-like, which is very different when you have to compare across these two disease states. Of course, a talk would be incomplete without a slide on myositis autoantibodies. So The myositis autoantibodies that we typically think about in dermatomyositis, I mentioned MDA5 right in the middle. Of course, anti-synthetase patients can also have dermatomyositis. Just because you are PL7 doesn't mean you're just going to have polymyositis. I think this is a misconception I commonly see when I work with the fellows. You can have dermatomyositis and PL7 and ILD. MDA5 associated, it's a rapidly progressive ILD. SAE does have more recalcitrant skin disease, very difficult to treat with whole body erythroderma. MI2 usually is more responsive to treatment with skin and muscle disease. We don't want to forget about malignancy, the TIF1 and NXP2. I think over the years, TIF1 is kind of becoming the leading kind of high risk association with cancer. But NXP2 still, we do worry about it. NXP2 is highly associated with calcinosis, something we don't want to forget about. And I put in overlap myositis here because I mentioned the calcinosis, right? With the scleroderma patients can have overlap with myositis. And if you look in the literature in the world of myositis, the most common overlap condition is scleroderma or systemic sclerosis. So we don't want to forget about these patients, PMSCL, COO, RHO, U1-RMP, and of course, U3-RMP is the one that's classically associated with diffuse scleroderma, African-American patients, and very myositis and severe GI dysmotility. Going back to the distinct cutaneous manifestations and why we like these myositis autoantibodies, the reason is that it can help us with diagnosis and also even prognosis. If I tell my patients, I'm like, okay, or even the fellows, I'm like, okay, we have to look at the patient's hands very carefully, because if I look at their hands and I see the kissing papules, I can tell them this is what you have. I mean, we can diagnose the patient right then and there. It's not something that needs a kidney biopsy or a lung biopsy or even a muscle biopsy, right? And this is a patient of mine who has the classic kissing papules in the palmar surface, and it's usually in the, the flexor areas, and it can be quite painful. The other cutaneous feature seen in MDA5 associated dermatomyositis is the really difficult to treat ulcers over the knuckles right here. Very difficult to treat, very refractory at times, and it can get infected. I have another patient right now who's had osteomyelitis in that bone and just recurrent disease, and we've been very aggressive about treating it. So I think, while remember I showed you that picture, there's a spectrum, amyopathic, hypomyopathic, and it's kind of definite DM or skin and muscles involved. I think the skin patients, they can have very recalcitrant disease that can be very challenging to treat. The other classic TIF1 gamma antibody I want to point here, Dr. Fiorentino's group, in addition to the Gotrins papules heliotrope rash, they reported at Stanford that the patients can have this ovoid palatal patch. I have seen it a couple of patients of mine, and it's interesting to look for. If you do a biopsy, then you'll actually see interface dermatitis, the same thing you would see if you did a skin biopsy of a patient with dermatomyositis. I do want to devote a couple slides to TIF1 gamma because there is a lot of data coming out about this high risk association with TIF1 gamma and cancer. And so when do we think about these patients and TIF1 gamma and that high risk association? I think it's really largely in patients who have refractory disease. So keep in mind that these patients will already usually have more extensive skin disease and refractory disease, but less likely to have ILD or Raynaud's. But the refractory disease, every kind of, I would say, there's no widely accepted, this is the definitive criteria for refractory disease, but most of the time it's patients who have failed high dose steroids plus or minus at least 2 steroid sparing agents. And that's when you're thinking, okay, did we actually do an age appropriate malignancy screening? Did we do a CT chest, abdomen, pelvis, or whole body CT? And this is something we don't want to miss. So recently, Dr. Hector Chinoy's group at UK, in the UK MyoNet, University of Manchester, looked at TIF1 gamma and malignancy risk. And, there are a lot of other studies that, replicate this study and support this and bolster this study. But when they looked at the 10-year cancer risk, when you compare TIF1 gamma positive versus TIF1 negative, they found that The malignancy usually occurs within a 3-year period on either side of DM onset. And you can see in this, KM curve that these patients after 3 years, if you're TIF1 gamma positive, is 40% versus TIF1 gamma negative. So the highest risk of cancer is about 39 years and older, and the most common is ovarian cancer. So I do think that these TIF1 gamma positive patients, not all of them will develop it, because if you actually ask, I've asked Dave Fiorentino once, and he's told us that the most common autoantibody they find in their dermatology clinic of DM patients, if you look across the board, is TIF1, is the most common autoantibody in dermatomyositis, but not everybody will have cancer. So I think it's something you think about in these refractory patients. Okay, so that was kind of the brief overview of dermatomyositis, the clinical manifestations, why these autoantibodies are important. Going to the pathogenesis, I think over time, no one really fully understood what was driving the disease. We knew that there's a lot of inflammation, there's complement deposition that you can see in the skin and the muscle tissue. But over time with the transcriptomic data, we now know the type interferon pathway is really the driving force behind the pathogenesis of dermatomyositis. So this is a complicated slide, but I like it because it shows all the type of pathways that are involved in dermatomyositis. But keeping this slide in mind, what do we do for treatment, right? Before transcriptomic data, what do we do for treatment? So the treatment paradigm was largely based on case control studies and uncontrolled clinical trials and case series. And the treatment paradigm of myositis, even before we knew about the whole interferon pathway, is that, of course, we're going to start with steroids, and then we use one of these 3 agents as first-line agents: methotrexate, azathioprine, and mycophenolate. And there is no head-to-head study. So what are we going to use? How are we going to decide what we're going to use? So it's really largely based on the organ manifestations. So if they have skin and muscle, plus they have joint disease, it's, after you do a thorough review of systems, then it's easy to say, well, we know methotrexate works in myositis, so why not we would use, methotrexate if they have concomitant inflammatory arthritis. And of course, even if they have amyopathic disease, if they have lung disease, then we're going to think about using azathioprine or mycophenolate. And there's no head-to-head study showing that one is better than the other, but certainly we take into account all the organ manifestations that can happen to decide on one agent in the beginning, one steroid-sparing agent in the beginning. And so that's sort of the treatment paradigm across all myositis. But if someone is not doing well, we're very quick to add combination therapy. And this is based on a lot of data that's already come out, including the RIM trial and also Dr. Delakis's seminal study of IVIG in 1993 that was published in the New England Journal, that we know IVIG works very well in treating myositis, especially dermatomyositis. And of course, if there's any red flag symptoms, you started the patient on methotrexate, one of these 3 agents, and after 3 to 4 months, they're not improving, then we need to add agents and use combination therapy. So these are the times when we think about IVIG and rituximab. Rituximab in myositis was the largest, the RIM study was the largest clinical trial in myositis. It was a bit disappointing, led by Dr. Rohit Agrawal and Dr. Otis. But at least we know that, not surprisingly, that post-hoc analyses show that the patients who have autoantibodies do respond the best. And so I think insurance companies know about this, and while it is a little more challenging to get approved, it can be achieved with appropriate letter writing skills, I suppose, and citing the appropriate studies. Okay, so what about if we focus specifically on dermatomyositis with the background set of what I showed you before in these last 2 slides? It's very similar in the sense that we would use steroids and use one of these first-line agents. But if patients do not respond, then as I said, Dr. Delakis's seminal study back in 1993, which is a placebo-controlled study, small group of patients, but we know that it works beautifully for skin and muscle. So we know that can be used specifically in the treatment of dermatomyositis. Rituximab. I told you for rituximab, the RIM trial included patients with PM and DM and juvenile myositis, but when they looked at the post-hoc analyses of rituximab, we also know that it can work for skin disease, especially about 28 weeks post. You can see the percentage of patients who had Gaucher papules decreased. So we do use rituximab for skin specific disease in dermatomyositis, or what we call skin predominant dermatomyositis. And I highlighted beginning of my talk and the outline that finally we have one FDA-approved drug for the treatment of myositis, and that is the ProDerm phase 3 study that was seminal in finally getting this FDA approval for IVIG. So the ProDerm study was using Octagam, which is a phase 3 randomized double-blind placebo-controlled trial of 95 patients. And in the first period, they did double-blind placebo-controlled for 16 weeks, because we know IVIG, if you give it a trial of 3 to 4 months, if it doesn't work, we know it's not going to work usually. So, and then after that, patients who are on placebo then went on to get the Octagam for 24 weeks. So the primary outcome here that they used was the proportion of responders who had at least a greater than 20 point on the TIS. And I have a slide on this later, but basically the TIS is a 2017 ACR-EULAR approved criteria with myositis response criteria, which has the basis of the definition of improvement of the IMAX definition of improvement, which is the International Consortium of Myositis Specialists who developed these clinical outcome measures to use in clinical trials for JDM, for juvenile myositis, and also in adult myositis patients. So that was updated in 2017 with given different weights, and that's the total improvement score. So that total improvement score actually includes 6 core set measures, you know, the physician global, patient global, the muscle enzymes, health assessment questionnaire, and the manual muscle testing. So when you compare those who received IVIG versus placebo at week 16, 78.7% actually had at least minimal improvement on this total improvement score. And the time to response was 35 days. This was not, you know, you might think this is pretty quick, but we know IVIG, when it works pretty quickly. And this was also supported by Dr. Dalakis' study in 1993 that patients had response within 2 months or even earlier. So I think this highlights why we use a lot of IVIG in myositis, especially in dermatomyositis. And as I showed you here, this is a slide from Dr. Rohi Agrawal, who shows the efficacy results in a beautiful manner, with the mean TIS, the total improvement score, improving at the 16 weeks. It was significantly higher compared to the placebo group. And then by the open label, you can see it plateaus out. Now, you might have seen, I didn't show you, but if I went back to the other slide, the placebo group does have, you know, quite good response rate. So I think we in the myositis community know that these myositis patients can have some high placebo rate, and hence the reason why we need these randomized phase 3 studies to really look at the efficacy of these drugs. Okay, so now we can say we have the first FDA-approved drug for dermatomyositis, which is really exciting. And I think it also bolstered the trust and the excitement around using the ACR-EULAR criteria, the 2017 response criteria, because it was a good tool, a good clinical outcome measure to push forward a drug for FDA approval. And I think this is why there's a lot of other excitement about other pipeline drugs as well. So going into the pipeline drugs and going back to the interferon pathway, I think I'm going to go into discussing why certain drugs are of interest. And the reason why is the interferon pathway. Why was there no trial back in 2015, or was there anything else back then to see if the interferon pathway, if you blocked it, would really work in dermatomyositis? Because now we know all this transcriptomic data in the skin, in the blood, and the muscles show that type 1 interferons are very important in dermatomyositis. So if you actually look in the literature, there is one phase 1b clinical trial of sifilumumab, anti-interferon alpha monoclonal antibody in dermatomyositis and polymyositis. Now, because it was a phase 1b, the outcome measure was actually a median target neutralization of interferon gene signature. In the blood, they looked here, and you can see, compared to placebo, sifilumumab actually lowered the interferon signature significantly more than the placebo. So about 60% decrease here. It was statistically significant. And in the blood, in the muscle, you can see there was also a decrease in the interferon signature. So we know it works, but it was a small study. They didn't have a lot of clinical measures that they looked at because it was phase 1b. And then I was wondering what happened to this study. This was very exciting. But second, there was no phase 2 study, unfortunately. But of course, there was interest in this pathway, directly blocking this pathway, because we know it's very important. So since then, Pfizer has developed a interferon beta monoclonal antibody now. And around 2017-18, they launched a phase 2 randomized placebo-controlled trial. And this is an infusion drug of adult dermatomyositis. So their primary endpoint was actually looking at skin-only outcome measures of the CDASI, which is a validated cutaneous dermatomyositis skin activity score developed by Dr. Vicki Worth at UPenn. And the outcome measure was to look at 12 weeks. But since then, they actually have expanded to look at muscle disease as well. Because as we all know, in the FDA, if you want to get something approved, you do have to show improvement in skin and muscle. So they did expand the study to include muscle patients, meaning they had to also have muscle involvement, not just skin alone. And they completed the trial, and we are recruiting a site. So I'm very much looking forward to the results of this study. Hopefully this will come out in the next year or so. Other pipeline drugs that are starting in is a multi-center phase 2/3 double-blind placebo-controlled trial is actually Alexion. So Alexion has this drug as a C5 complement inhibitor. And the thought is, why don't we block this pathway? Because we know if you do, especially muscle biopsies, I mean, the ENMC criteria to look criteria for muscle histopathology features that are diagnostic for dermatomyositis include C5 to 9B MAC complex deposition in the muscle. So not surprisingly, there's thought and a lot of evidence to think, well, if we see that, if we block that pathway, maybe we'll see some benefit in dermatomyositis. So right now, this drug is already approved for myasthenia gravis. And now they want to look at it in dermatomyositis. So this planned phase 2, we're recruiting site as well. And it's a multi-center trial. They're going to do a phase 2/3 study. So the thought is, you're going to directly inhibit C5 activation and hopefully will lead to improvement. And they are looking at the ACR, the 2017 ACR-ULR TIS as the primary outcome measure. And we're hoping to recruit very shortly for this study as well. So I think there's a lot of different ways to attack the problem in dermatomyositis. And this is why it's very exciting in the myositis world right now, because there's many pipeline drugs coming out. So now I'm going to go and discuss the JAK inhibitor story, or the evolution of JAK inhibitors in myositis, especially dermatomyositis. So the first clinical case report that was published in the New England Journal, and this is that very first case report ever, was in December of 2014. And I remember distinctly, it was December 25th, it was Christmas, and this came up on my feed. And I was like, oh, wow, this is very interesting. And the reason why, I will tell you why in the next slide, but this case, the first case was a 72-year-old female who had myelofibrosis and was treated for her myelofibrosis with ruxolitinib, a JAK inhibitor. And interestingly enough, in this case report in Germany, they reported that this patient actually had improvement in their skin and muscle disease. And the thought was, well, it made sense mechanistically because the JAK inhibitor regulates the JAK-STAT pathway, regulates activation of dendritic cells. And if you block that interferon beta-induced signals through the STAT, they know that in vitro and vivo, potentially it's going to help with controlling the disease process. And this patient was able to taper steroids and do very well from a dermatomyositis perspective. So why I thought this was most interesting was because what I will go into this. Why I thought this was most interesting was that at the same time, I guess same good things happen all at the same time, was that I had a patient who had refractory dermatomyositis, and she was TIF1 and positive. And she was just like, Dr. Paik, I've tried everything. I've tried IVIG, I've tried, rituximab, azathioprine, mycophenolate. I mean, you can name the whole thing. And she was pretty at her wit's end. But she also had a little bit of inflammatory arthritis, and tofacitinib had just come out on the market. So maybe a year or less, Pfizer had just come out with tofacitinib at that time. So we decided to use this drug. And by divine intervention, I mean, she called within about 2 months in tears, saying that she was able to go out with her friends on vacation and not have to be so covered up and things like this. Although I did remind her, you need to put sunscreen on. But she was so happy that she could go out and just in tears. And I think it was just the remarkable response she saw in her skin disease. And it was really what was driving her refractory nature of the dermatomyositis was really skin. But TOFA, when we put her on this drug, had a remarkable response. So good things happening all at the same time. There was also a case series of about 3 patients, I believe, by Dr. Ruth Ann Voigel's group, the autoimmune kind of skin clinic expertise of Dr. Ruth Ann Voigel's, who also reported that the patient had some improvement with tofacitinib. So this ultimately led to a collaboration with Pfizer. After multiple meetings and trying to convince them and pitching to them that this drug potentially can work mechanistically, makes sense, but ultimately, if it wasn't for the support of my patient and also, of course, my mentor and sponsor, Dr. Lisa Christopher Stein, who was my biggest cheerleader, that this one idea can actually lead to a potential proof of concept trial. Because, when we do this stuff meaning, our work and trials and designing trials, is really all for the patient. And that all makes it worth it at the end. And so with this collaborative study we did with Pfizer, the goal was, we thought, and the hypothesis was that tofacitinib would reduce the skin involvement and improve muscle strength in patients with refractory dermatomyositis. And it would also inhibit the production or secretion of pro-inflammatory key chemokines as CXCL9 and CXCL10. And just to, I think, to remind ourselves, the JAK inhibitors at the time was tofacitinib, and they called it the pan-JAK inhibitor, but because it blocks JAK1, 2, and 3, but mostly JAK1 and 3. And ruxolitinib and baricitinib is mostly JAK1. So it makes sense that if you block this pathway, that the interferon pathway should, the interferon signature driving the disease should actually improve the disease state in dermatomyositis. So going back, so after getting funding from Pfizer in this collaborative trial, which took some time, but finally it was approved. And the inclusion criteria included probable or definite DM by Bowen and Peter criteria at least 6 months before screening. And because it worked in my patient with refractory disease, we wanted to use it specifically in refractory DM as a proof of concept study. So our definition of refractory disease was that they had to have active disease despite a 12-week steroid trial and failure of response to at least steroids and 1 first-line immunosuppressive agent. And I put this in red because we also wanted to have active DM. So it had to be skin biopsy proven with or without muscle weakness. So they could have skin or muscle or both. And so MMTH score of less than 142 out of 150 and the CDASI score of at least 5. And again, this is a skin assessment of dermatomyositis. And if you have at least 14 and higher, usually means moderate to severe skin disease. And the reason why I kept it low when I wrote this protocol is that I wanted to also include patients who had muscle disease but very mild skin. But you'll see what type of patients we actually ended up recruiting. The other big point for this trial that I really wanted to do, and I did get some feedback from my colleagues about it in terms of concerns about recruitment. But I think, when you're kind of focused on doing this study and you want it a certain way, I really wanted to have it as a pure study. So we did washout of immunosuppressive agents. So they had to wash out of methotrexate, azathioprine, mycophenolate, Plaquenil, IVIG, rituximab, and cyclophosphamide. And so you can see here that they had to be washed out. And the people who could not tolerate the washout, we actually allowed prednisone about 20 milligrams per day. At least there had to be a stable dose for 2 weeks before a baseline visit. Not everybody required this, and I will show you. So the study design, again, at screening 30 days before, and then baseline visit, we did skin biopsies, muscle biopsies, needle muscle biopsies, muscle MRI, and research blood. And then week 12 was our primary endpoint. And at the time, TOFA came out with a long-acting 11 milligrams XR daily. So this was nice for to make sure compliance was not an issue. And then we also, again, to emphasize the point of trying to make it a pure study, we tried to force the prednisone taper. And it doesn't mean that, like, if someone flared, then of course we would give more prednisone, but we institute a prednisone taper so that if you're at 20, then you would gradually be off by week 12. And I wanted to highlight, this was a humbling experience, when I was a junior investigator back several years ago, and transitioning into this mid-career stage. Back then, this was my first clinical trial, from concept to, execution. And it was a humbling experience because you think, oh, we're 10 patients, so easy to do. But on paper, it's easy. It was a very humbling experience, again, to highlight that. And without, these amazing research coordinators, Sherry Leung, who came in, I really want to highlight that without her help, it would have not been possible. And of course, Doris Leung, they're actually sisters. She's a neurologist who helped do the muscle biopsies, the needle biopsies. And then when Sherry left, which is a very disappointment, but she's on to much greater things now, but Grisina and Regina Greco also helped. So just wanted to highlight those people because these even simple studies like this it really takes a village. And I think it was a great experience for me, but without these people, it would have not been possible. So the primary outcome, again, we're looking at week 12, and we use the definition of improvement by the IMAX, as I mentioned previously. And that definition is 3 of any of the 6 core set measures improved by 20% with no more than 2 worsening by 25%. But at the same time, when this trial started, the myositis response criteria in 2017 came out. So we also use that to assess the response rate. So again, these are the 6 core set measures I mentioned before: physician global, patient global, manual muscle testing, the health assessment questionnaire, the muscle enzymes, and then this extramuscular disease activity. And then the total improvement score, we divide into minimal, moderate, and major. So if you have at least 20 points, it's minimal. If greater than 40 points, moderate, and major is greater than 60 points. Okay, so going back to the proof of concept study, knowing that background of the TIS, when we tried to recruit people, what we found was we actually had much more patients who had skin predominant disease at our myositis center. So in this red box, I'm highlighting the fact that while we really tried to recruit patients who had, muscle involvement, you can see the CDASI is very high, but the MMT is not low, meaning that the patients were not very weak. And this is also supported by the CK not being very high. So the overall phenotype of the patients that were in this proof of concept study, they were skin predominant disease who were refractory. So the disease duration was 6.45 years. And the most common autoantibody, not surprising, was TIF1 gamma because they had skin predominant disease. And they failed multiple agents here, as you can see. So the result of the proof of concept study, the primary outcome measure, again, was the median TIS, the mean TIS that we looked at for the response rate. And you can see this is on the panel on top is all 10 subjects combined. And you can see that the response was seen pretty quick, about 4 to 6 weeks here. And you can see it plateaus off at 12 weeks, which is our endpoint. But if you actually take a little bit deeper dive into looking at each subject themselves, it is a bit heterogeneous. Some patients actually responded very quickly. Other patients responded a little bit slower, but overall by week 12, they had a good response with a median TIS of 40, indicating moderate improvement in all 10 subjects. The secondary outcome measure was the CDASI. And again, anything 14 and higher is moderate to severe, but you can see that the median CDASI of all 10 patients was about 20. So indicative of pretty, moderate to severe skin disease at baseline, and that improved by week 12 to about 10 or less. And here are some pictures of these patients. Now, this patient, I remember specifically, she was not on any steroids. She was previously on IVIG, and she had to wash out of everything else. She did not require any steroids. She actually didn't want to be on steroids because she's had long-standing disease. And you can see how active and angry her skin disease is. The shawl sign, and it extends up to the neck, and she had extensive skin disease here in the back as well and in the front. So her skin, if I remember correctly, her CDASI was in the 50s, which is pretty high. And by week 12, this had all completely resolved. And this is resolved, but a little bit in the neck is left here, as you can see. And then this is the same patient. You can see this V-neck sign, angry red. This is mostly resolved by week 12, but still extending a little bit up to the neck. And we also did muscle MRIs pre and post treatment. And we didn't do any quantitative like T2 mapping or anything like this, but so it's mostly qualitative, as you can see. But at baseline, you can see that the subacute edema was here and that's resolved by week 12. And you can see mild edema and T2 stir imaging here in the anterior compartment and the posterior compartment that resolved by week 12 as well. Some of the exploratory endpoints we looked at were 7 subjects, because there were a lot of patients who were TIP1 gamma positive, wanted to see if did their autoantibody titers change over time, which it didn't. And, you know, it would have been a nice story to say that the antibody titer resolved or improved, but there is a lot of data showing that, especially in dermatomyositis, the titers don't associate with disease activity at all. But when we looked at these patients, 70% were moderate responders and 30% were minimal responders. I mean, can't make formal conclusions, but the TIP1 gamma patients tended to be a little bit, there was a trend that they were better responders. And the prednisone taper, we had 4 patients who at entry were on 20 milligrams per day. And 3 out of the 4s were completely able to taper off all steroids. The last patient started at 20 and was able to get down to 10 by week 12. But for him, it was a remarkable improvement because he had been on 15 to 20 for about 10 years of his life. So this was a huge thing for him. So despite that last patient not being able to taper off, it was still an accomplishment, I think, for him to be able to taper to some degree. Again, it takes a village, and while I did the skin biopsies, definitely needed our RDRCC collaboration that's led by Dr. Livia Cassioma-Rosen to do the STAT1 immunohistochemistry. And you can see here in these patients, now we can actually show that STAT1 was downregulated in the skin by immunohistochemistry. So at baseline, you can see there's a lot of staining, and then by week 12, this is significantly improved in these 2 patients. I mentioned CXCL9 and 10 as important biomarkers of disease activity, and we also found that there was composite downregulation from baseline to week 12, highlighting that both interferon, type 1 interferons and type 2 interferons were important in disease pathogenesis, and it associated with improvement in disease. And it's interesting because CXCL9 is actually induced by interferon gamma or type 2 interferon, but not interferon alpha and beta. And CXCL10 is strongly induced by interferon gamma as well as type 1 interferons. And why that may be important is that I talked a lot about type 1 interferons and the figure that I showed before, but I think potentially the JAK-STAT, the JAK inhibitors work pretty well in this proof of concept study, is that you're blocking also the type 2 interferon pathway. And you can see here for interferon gamma, it's the same process as the STAT. JAK-STAT pathway being involved, and this may explain why these patients had an improvement so quickly, and also potential an improvement seen in the study. So we also did some exploratory analysis and data gathering with RNA sequencing, and what we did was we looked at blood, skin, and muscle. And interestingly enough, in the blood, I was expecting all the interferon-related genes to be downregulated. So in this volcano plot, you can see on this left upper corner means that these genes were downregulated, and a p-value of less than 0.5, and at least a log fold change greater than 1.5. But interestingly enough, none of those genes were downregulated in the blood. So the genes of interest is actually a complement pathway. And this may highlight why, the Alexion drug that I mentioned before may be potentially very beneficial in some subset of patients with dermatomyositis. And just want to highlight my other collaborators, Liliana, Karina, and Jinshui and Joseph, who was able to help me interpret all this RNA sequencing data, and working with them was a true pleasure. And when you look at the skin, I mentioned, on immunohistochemistry, the STAT1 was downregulated. So in these specific patients who had this response, we looked at their RNA sequencing as well. And with pathway analysis, we're able to show type 1 interferons and type 2 interferons were significantly inhibited in these patients. It's about 40-fold change. So I think, again, it's highlighting these type 1 interferons and type 2 interferons can be important in dermatomyositis. And finally, in the muscle, we were able to see that not only the complement pathway was downregulated, but also these interferon-related genes are downregulated in the muscle. And so IFI27, MX2, IFI6 were downregulated. And this is just a slide to show that there's a lot of evidence to show that downregulation of type 1 interferon gene, type 1 interferon genes are very important in dermatomyositis, especially in the muscle. So not surprisingly, we found that this was downregulated when we inhibit this pathway using tofacitinib. So overall, the summary of the RNA sequencing data, we found type 1 and type 2 interferon downregulation with CXCL10 and 9 being downregulated. And we also found the complement pathway being downregulated. And then I didn't show this data, but we also calculated interferon scores in the muscle. And the 8 patients who had muscle biopsies pre and post actually had a decrease in their interferon gene score in the muscle. Okay, so overall, how was this drug tolerated? So the drug was pretty well tolerated. There was no serious adverse events. No one had any, VTE or clots. Fortunately, no one had any severe zoster infection. And there were no serious adverse events, no hospitalization. One non-serious adverse event was this recurrent UTI in one of the patients. She finished the study, but she obviously didn't want to be on, suppressive antibiotics long term. And she did have a history of UTIs in the past. That was one adverse event that we did notice in our one patient. Because of these results, in discussing with our collaborator, Pfizer, we decided to see the long-term effects of this drug in these patients. So we actually looked at the data long-term for up to week 96 weeks. So they continued the drug for an extended period of time. And 7 of the 10 patients entered the long-term extension study, and 86% met that definition of improvement in 96 weeks. And you can see at 72 weeks, the median TIS was 35, and then at 96 weeks, it was 25. And the mean baseline CDASI was 25, and it dropped to 4.71 at week 96. So the skin really responded beautifully. And you can see this is the same patient. She continued the drug. This is week 12, and this is week 96. Now you might say, oh, there's some little red, but this is actually really poikiloderma that's not showing up very clearly here. But if you look closely, you can see it's really not any disease activity at all, but poikiloderma, which is some damage from the post-inflammatory disease changes in dermatomyositis. Another interesting finding we saw in the study was that we had 3 patients who had significant calcinosis burden. And, the patient themselves were telling us, well, I feel that my calcinosis is better. And, it's hard to attribute that to the drug at the time. We're thinking the disease is getting under control. But it was interesting when we went back after the study was complete, what we found was that the patients who had calcinosis, because we had the luxury of doing pre and post MRIs at baseline and week 12, you can see on the STIR study, there's this area of calcinosis. And by week 12, this is completely gone. And then here on the T1, you can see the calcinosis, and that's gone. And this actually came out from her leg, and she's a very motivated patient and was very excited her calcinosis was improving. It was so close to the surface, it was extruded out of her skin. This is another patient that we reported in this case series of these 3 patients. On T2, on the STIR, you can see this edema, and then you can see that this edema is gone, that signal is gone. So the calcinosis is resolved. And then you can see this indentation where the calcium was, and then this is gone. And she happened to have x-rays as well. And you can see it's more formed here, and then it's less here. So when we were writing this case series, I was thinking, oh, this is, a very interesting finding that we observed during the study. But actually, if you look in the literature, there are a couple more case series and case reports of JAK inhibitors improving calcinosis. And one of them was an adult dermatomyositis patient, 16 weeks post-treatment with tofa and methotrexate. And they even had beautiful DECT images. But you can see here, this is, before treatment, and this is after treatment. And here you can see the DECT scan, the calcinosis improving after treatment. And you can see less of the purple here. And then there's a patient, it was a case of a JDM patient where you see after 3 months post-treatment with tofa that the calcinosis also decreased in size as well. So this is very fascinating, and I think we need to understand that a little bit better. But I think this is it was very exciting to see that there was some improvement. Of course, I can't fully prove cause and effect, but may just because the myositis is improving in and of itself. But I think this was a very interesting observation. Just to highlight, speaking with our juvenile DM myositis colleagues, and in the literature, there's a lot of interest in JAK inhibitors as well. And Dr. Hannah Kim led a proof of concept study as well in juvenile dermatomyositis. She looked at these 4 patients, and you can see the CDASI also improved, and the MMT8 or the muscle strength also improved. And this is just a case report out of the UK showing that this patient, a young patient, failed multiple agents, including cyclophosphamide, and had some improvement after using baricitinib. And in her trial, she used baricitinib as well. So I think this is a promising potential drug. I think it's a little bit early to say if it's be all end all, but there are some interesting trials actually going on now. And going back to my figure, there is a phase 2 study that's now being led by Dr. Hector Chinoy and Dr. Ingrid Lumberg in the UK in Manchester, looking at baricitinib as an add-on therapy to, so basically they're allowing baseline immunosuppressant, at least one, and then you're adding on baricitinib to that drug to see if this add-on JAK therapy would help control disease in dermatomyositis. There's also at the Myology Institute in Paris, they're looking at using JAK inhibitor baricitinib early on in disease. So I think there's going to be a lot more data coming out about JAK inhibitors. And there is also a lot of interest looking at JAK inhibitors in ILD as well, which I didn't really touch on today, but there is a study of about a handful of patients out of Asia looking at patients who are MDA5 positive with ILD, and they were given tofacitinib, and they had improvement in their lung function measures and mortality. So there is a lot of interest in looking at JAK inhibitors, specifically in MDA5 associated ILD, because MDA5 we know has a high interferon signature. And then again, I think a lot of interesting trials coming out, and I'm very looking much forward to the anti-interferon beta trial that just finished in the complement inhibitors. So I think there's a lot in the pipeline, and hopefully I was able to impart to you that this is an exciting time for dermatomyositis and for promising therapeutics in dermatomyositis. And so this is my last slide, conclusions. Besides imparting to you that it's an exciting time, I was able to impart to you that dermatomyositis is a complex multi-system disease. And beyond type 1 interferon pathways, I do think type 2 interferon pathways are important in the pathogenesis of DM. And hopefully IVIG is our first FDA-approved drug to treat DM, and there'll be many more. And there's multiple pipeline agents that I can't, that I've mentioned, and then that I cannot, and other ones I cannot mention, but they're very exciting times in myositis right now. So thank you so much for your attention. This is our entire team. We have a multidisciplinary team, and thank you. And this is, if you follow Twitter, I'm on Twitter. And if you have any questions, please do not hesitate to ever email me. Thank you very much.
Thanks so much, Julie, for a really excellent talk. It looks like there are a couple of questions already, and we have, just checking the time, a couple of minutes, maybe then just diving right in. Dr. Wall asks, are there patients in whom you'd specifically be inclined to avoid JAK inhibitors?
Yeah. Wait, I think, yes. I think this is challenging now because, all the JAK story and the black box warning and all these things. So if a patient has a history of stroke and clotting, I tend to avoid it. But have I used it in combination with IVIG? Yes, I have, and I haven't had any issues. I think it's just an upfront conversation with the patient. And if you look at one of the first studies that came out as looking at baricitinib, it was published in Brain from the Myology Institute. They had patients who had improvement in their dermatomyositis, and they were on combination therapy as well. So I think you may see that in the future, but absolutely, if they have history of stroke and clotting, tend to avoid it. But if they don't have a history of that, I'm not just going to avoid it because I'm worried it's going to develop even in combination with IVIG. Yeah.
Got it. I think, Trent, lots of interest. I think there are hands raised too. I'll try and get to people in the order that they've raised their hand or chimed in. Dr. Chung asked, thank you so much. Topical JAK inhibitors, ruxolitinib, are being used in atopic dermatitis. Any studies looking at this for cutaneous dermatomyositis?
Yes. So you can actually now, with a compounding, I don't know how it is in Washington, but I think this is all over, the United States. You can order topical JAK at TOFA at a compounding pharmacy. And there are case reports, I believe, by Avery Lachance and also Ruth Ann Voigels, where they use topical JAK over the eyelids for cutaneous amyopathic dermatomyositis, or amyopathic dermatomyositis where their skin is very severe and showed improvement, like pre and post pictures. So I have started using this, but ordering things through the compounding pharmacy sometimes is challenging for mild cutaneous DM. And yes, so there are some case reports on it, but there is no formal clinical trial looking at it. But I think it's another option, especially if you can't. I have some patients who have really bad heliotrope rash and the tacrolimus doesn't work and you don't want to put steroid ointment on your eyelids, like clobetasol. Then this might be something you want to use. Yeah.
Got it. Thank you. Dr. Gardner, Greg asks, Julie, wonderful discussion. How often do you see dermatomyositis with muscle involvement and normal muscle enzymes?
Yeah. That's an interesting question, Dr. Gardner. I think, so I always say in dermatomyositis, the CK can be like mildly elevated, but they can be extremely weak. I tend not to see patients who have completely normal muscle enzymes and have frank overt muscle weakness. But again, like that hypomyopathic group, they can have normal muscle enzyme, but they may have some fasciitis and very mild patchy muscle edema, but be extremely strong. So I've seen those cases. But I tend to watch them and I don't really treat them if they're extremely strong. Yeah.
Dr. Elkon asks, seeing is believing, skin is good. What about muscle biopsies after tofacitinib?
Yes. So in our study, we were only able to do needle muscle biopsies, and that does not allow for us to look at histopath. But that's why we did the RNA-seq, and the type 1 interferons gene signatures seem to be downregulated after using the drug. Now, clinically, I would have to say there are some case reports that muscle strength definitely improves with JAK inhibition. But I think, and I showed you the muscle MRI where you can see that the muscle edema improved, but I really think it takes longer than the skin disease to see the improvement. Like I showed you, like the skin responds very quickly, usually, within 4 weeks or 6 weeks, you're going to see what you're going to see with the improvement pretty quick. But the muscle strength, I think, takes a bit longer. And so I guess because we did this study, I do get a lot of questions. Well, would I use TOFA for more refractory muscle disease? And I would say I wouldn't. I would use IVIG first because we know that works better in muscle. And I think we need a little more data about how much of an effect clinically we can see with TOFA in improving muscle strength.
All right, thank you. Dr. Thomason asks, this fantastic talk, thank you. Wondering about other approaches to calcinosis that you all use, sodium thiosulfate injection or topical or other approaches. Great to see the data about improvement with JAK inhibitors. So, what do you all do for calcinosis? You have a magic silver bullet, right?
No, I wish I could say we did, but yeah, nothing really works. I mean, it's really kind of, and so that's why I think this JAK was very exciting, but I mean, certainly we need to have a bigger trial to look at it. Borrowing from my scleroderma experience, if you have, sodium thiosulfate, you can use that on the fingertips, and sometimes, it helps. I even asked my derm colleagues about the injection, because I know one of my patients were like, I want to do these injections. What do you think about this? Like directly into my calcinosis. But I've been told that it's extremely painful and doesn't really help, and it can reoccur. So I wish I had a better answer to that. It's really challenging. It's really challenging. I do think treating aggressively up front definitely helps. That's what we know about in JDM. But in adults, it is challenging because it can happen later in disease and not at disease presentation. Yeah.
Got it. Thank you. A couple of people, someone whose name isn't posted, and then Dr. Singh were asking about cancer screening and what your approach to cancer screening is.
Yeah, when we look back, and when any new patient comes to the myositis center, they were getting like pan-CTs at our center, and we actually found that we did not see a high percentage of detection of cancer. So we really, and it's sort of radiation exposure and all these things. So our current kind of practice is, if they're refractory to treatment, then we do a little bit of a deeper dive to look for an occult malignancy. And that could take the form of doing a PET CT scan, or whole body CT scan, and age appropriate cancer screening. But I think, have you been able to get, it's very hard to get approved. It's extremely hard to get approved. So we're now trying to start a study to look at specific high-risk groups and do more extensive cancer screening. My colleague, Dr. Chris Meckley, is very interested in this area. So, he's starting to look at that to see, is there a utility to actually do it? Because I know we're like scared and we want to do it, but we can't do it, get the insurance approved to get a PET CT, but does it really help? So hopefully more to come with that in terms of the cancer surveillance.
Thank you. And I think we're at the top of the hour or just past, so I want to respect your time and everyone else's time, but a really, I think, important comment from Dr. Mantilla about getting representative images into, say, like the ACR database or another database from people with all different skin tones. So,
yes, extremely.
That would be great.
Yeah.
Well, I think we're out of time, but thank you, Julie. Thank you, Dr. Paik, for really a fantastic talk, and thank you everyone for contributing questions. I think we'll have to end it here though, since we're out of time. Thank you again.
Thank you so much for having me.